grand rounds of the semester. So we're the Office of Public Health Practice and Research, and we will be having a number of both seminars and grand rounds coming up on the current in the semester to come. You are welcome to go to our site, which is on our website, which is part of the college, and then under the Office of Practice and Research, and you will see what our seminar schedule is, as well as a number of the other research and practice activities that we have going on. So we are today greatly honored to have Mr. Meit, who is Director of Research and Programs at the Center for Rural Health Research, and then he's also a Research Associate Professor in the Department of Health Services, Management and Policy in the College of Public Health at East Tennessee State University. And today, Mr. Meit will talk about an area in which he has a great deal of expertise, which is the interface of health equity, poverty, and rural health. There's additional information about him, and I'll let him share that. So without further ado, to give him as much time as he needs, I'm going to turn it over to Mr. Meit. And then, Mr. Meit, welcome to Southern.
Thank you very much. I'm going to open up my slides here.
Okay, go ahead.
All right, perfect. Here we go. So thank you for having me. So again, I'm Michael Meit. I am at East Tennessee State University, where I'm the Director of Research and Programs for our Center for Rural Health Research. I'm also a senior fellow at NORC at the University of Chicago, which was my prior employer, and I've been able to keep a post there with their Walsh Center for Rural Health Analysis. The work that I've done, the work that we've done over the years has really focused on what I refer to as rural public health. We've had this field of rural health, which has tended to focus on access to care issues, and public health, of course, has focused on broader health disparities, but often has not looked at those disparities based on geography. So trying to really blend that rural piece with the public health piece is kind of surprisingly understudied. And so what I want to share today is some of the findings from some of the research that we've done, some of the research that others have done, really looking at these intersections between health equity, poverty, and rural health. So as you get started, whenever you talk about rural, the first question people ask is, how do you define rural? And unfortunately, that's not an easy question to answer. The federal government uses 74 definitions, 16 primary definitions. The one thing I like to point out is that there is one common thread between every one of these 74 definitions, and that is that they are definitions of exclusion. So rural is always defined as not urban, which is not great. You want to be defined for what you are, not for what you're not. The definitions that do exist, it really is, it's a wide array. Sometimes it's by county, sometimes census tract, sometimes zip code. There are multiple grades of rural within that. What you have to remember is the reason why we have rural definitions is really to have exclusion and inclusion criteria for grant programs. And that's why it is so variant. And the problem that we have in the United States is that our rural areas are very diverse. East Coast rural does not look like West Coast rural, does not look like the Plain States. So it's hard to have one definition that fits for everyone. And kind of by default, we end up with definitions that often don't work well for specific communities. In total, though, roughly 16 to 20% of our population lives in rural areas across these definitions. So that gives you an idea of what rural looks like. This is a slide I like to start with. So this is age-adjusted mortality by sex and rurality for the entire United States. It's a trend line between 1999 and 2015. What you see here is not rural versus urban. What you see here is rural compared to the entire United States, rural and urban combined. The reason I show that is that this gray line is what we often talk about in terms of our success as a nation in addressing health outcomes. We like to talk about how life expectancy has increased, mortality has decreased, generation upon generation. And you see that in this gray line where life expectancy has continued to go up, mortality has continued to go down. And in fact, until 2018, we had declines in increases in life expectancy ever since 1993. 1993 was the first year in many that life expectancy had gone down because of the AIDS crisis. 2018, they'd gone down because of the opioid crisis. But really between those two timeframes, we saw this steady improvement in health status. The green line, rural. I show it this way because you see two things. One is that the line has gone up really across this whole time frame. So even when we talk about improvements in health outcomes in the United States, our rural communities have often not shared in that success. And in fact, the disparities have grown. You see those lines are getting further apart. So what does this look like when we think about leading causes of death? So this was from a recent MMWR article that the CDC did. And this is looking at excess mortality. And what you see here is the lines to the right, those darker lines are our rural communities. And across the 5 leading causes of death, rural fares worse than non-rural. So back to those definitions, when you look at this, you'll see the 2 lines on the end, they're micropolitan and non-core. Those are both rural designations. The other 4 bars are urban designations. So you're comparing the first 4 to the last 2. And you see that across these different gradients of geography, the more rural you get, the worse the health outcomes get. And in fact, at the Walsh Center, we looked at this across the 10 leading causes of death. And we looked at it by, we looked at it for every state in the nation, as well as a couple of regions within the nation. This is the data for Georgia. So this is males age 25 to 64 in Georgia. The way to look at this is the orange and red dots are the 2 rural designations. So that is the micropolitan and the non-core. Orange micropolitan, red non-core. The line, the 100 line is the national average for mortality rates for each of these 10 leading causes of death. What you see here is that as a whole, as a state, Georgia doesn't fare particularly well, but it's those rural communities where the disparities are greatest. And then if you look along that y-axis, you'll see, so for example, heart disease, the orange and the red dots are on top of each other, so you only see the orange. But if you're a male in the state of Georgia living in a rural community, you have about a 70% greater likelihood of dying from heart disease than males in the rest of the United States. If you look at lower respiratory disease, you have about 50% greater likelihood of dying from lower respiratory disease. So you see this across most of the leading causes of death. The one exception is homicide, which for males tends to be more of an urban phenomena, although there's still a rural disparity. For females, a couple of things I want you to see here. First, the lines are much, much higher. So what we see is that overall mortality rates are lower for females than males, but the disparities are greater by geography for females than males. So we mentioned that males had a 70% greater likelihood of dying in Georgia from heart disease. Rural females, it's twice as likely. Lower respiratory disease, about 90% greater chance. And you see that across the board. Do also note the homicide line, and this is something we see in a lot of states in the country. The homicide rates for urban males tends to be higher. For females, there is a rural disparity where for females, so you see micropolitan females here, are twice as likely to die from homicide. So, you know, this really is an indicator, we think, of domestic violence. So it's something that I do like to draw attention to because I think it's an issue that is underreported and often under the radar in our rural communities. And then this just shows the exact same data looking at trend lines. So between 2014 and 2017, and you again see that orange line, the rural line, is higher than the urban line almost across the board. Homicide, the one exception for men. But look at how high some of these are, like heart disease, also notice that the disparities, even over this 4-year time frame, have grown for some of these conditions, such as heart disease, such as septicemia, lower respiratory disease. And very similar, you see the same trend lines for women. So bringing this to kind of the issue of poverty, this is national data. So one of the things that we like to look at is the influence of poverty on health. And what you'll see here, and all of these slides are a comparison of the wealthiest 2% of counties in the nation to the poorest 2% of counties in the nation, and kind of what that means relative to health outcomes and well-being. And for premature death, years of potential life lost, you see that there are almost 3 times as many years of potential life lost in our poorest counties as compared to our wealthiest counties. Smoking rates are about twice as high in our poorest counties as compared to our wealthiest counties. Obesity is about 50% higher in our poorest counties as compared to our richest counties. When you look at educational status, this is reversed. Our poorest counties, about 41% of the population has some college compared to 76% in our richest counties. And then in terms of children living in poverty, it's really dramatic. It's about 6 times greater in our poorest counties compared to our richest counties. And of course, what I'm showing you here is poorest versus richest, not urban versus rural, although we know that poverty is concentrated in our more rural counties. Not that there are not places in our nation where there's extreme poverty in our urban counties, but the vast majority of these poorer counties are rural, and the vast majority of these wealthier counties are urban. So why is this? So this is data from the USDA Economic Research Service. And to me, this kind of tells the story almost all by itself. So what you see here is job growth in the United States, the percentage of the population that is employed. And you'll note that prior to and through the recession, urban and rural employment was almost the same, but the recovery following the economic recession was very disparate. Our urban communities recovered strongly, our rural communities did not. And you'll note, if you look at 2007 compared to 2018, the rural employment rates are still lower than they were before the recession 10, 11 years later. So what I want to talk about a little bit is kind of what this means in terms of prosperity, which is kind of another way to think about poverty and economic opportunity. And one of the things that we did while I was at NORC, and we continue to work on this, we developed this prosperity index. And we did this with support from the United States Department of Agriculture. We convened an expert panel, really preeminent experts on measurement and prosperity and resilience from around the country. And we pulled together a 16 measure index. And what you see here are those 16 measures. A couple of things we wanted to do. We wanted to have something that was balanced, that was not just focused on deficits, but also focused on strengths. So we think about both risk and resilience factors. And then we also wanted to think about economic factors that were drivers of prosperity, as well as social factors. And you'll see we tried to come up with 4 measures per cell here. As we selected these measures, the other thing that was really important, 2 things. One, we wanted to make sure that the data were available at the county level so that we could create this index for every county in the United States. And we wanted to select measures that were things that could potentially change over time. So the idea is that if we provide information on all of these measures for a county, as part of their community planning, they can think about how they can decrease their risk and increase their resilience. So again, I'm not going to walk through all of these, but you'll see there's a real interesting variety, I think, of measures. including the number of nonprofit organizations per capita, the number of people who are self-employed, teen birth rate, labor force participation rate, et cetera. So when we compile all of those measures and we equally weighted them, this is the map of prosperity in the United States. Blue is highest prosperity, and the deep orange, the almost red, is the lowest prosperity. And I really want you to kind of focus in on that orange and see where that is. You'll see a lot of the regions of our country that we have defined kind of as regions that we recognize. So you'll see Central Appalachia, where I am. You'll see the Deep South, the rural South, where you guys are. You'll see the Delta region, the US-Mexico border region, and you'll see Indian reservations. That's where we have the lowest prosperity, the highest poverty within our nation. And so showing this a couple of different ways. So the map on the left is almost a perfect representation of those deep orange counties. And again, that is where we have the deepest poverty within the United States. So I like to show persistent poverty counties. So the definition of persistent poverty, and I kind of find this remarkable, these are counties where greater than 20% of the residents in that county live below the poverty line since the 1980 census. So we're talking about counties with 40 years of intergenerational poverty. And you'll see on that map on the left, you'll see the deep red is rural counties, and the slightly lighter red is urban counties. So you'll see that the vast majority of persistent poverty counties are in fact rural. But again, if you look to the right, you'll see that our prosperity index did a pretty good job without having a lot of direct measures of poverty. We did a pretty good job of actually showing which counties have the highest poverty rates. And then of course, that is very predictive of health outcomes. So again, left side, you have cardiovascular disease mortality, right side, you have the prosperity index, and you see again, very similar profiles in terms of poverty, lack of prosperity really being a strong indicator of cardiovascular disease, and same thing with diabetes. And again, you could go through almost all of these leading causes of death, and you would see very similar outcomes where that lower prosperity really is indicative of areas that struggle more in terms of health outcomes. Interestingly, there's also this strong tie back to race and ethnicity. So the map, and I'm going to show you a few of these. The map on the left, this is done by colleagues at the South Carolina Rural Health Research Center. The map on the left shows where African Americans live in rural counties in the United States. And again, you see the rural South and the Delta region, but that is almost a pullout of those darker, lower prosperity counties within our prosperity index. Similarly, this is the map that shows where Hispanic populations live in rural counties in the United States. And again, it's very similar to the prosperity index counties in the US-Mexico border region. And then finally, this is where American Indians and Alaska Natives live in the United States. And almost all of these counties are the ones that pop out within the prosperity index in the upper plains states. So again, strong associations between lower prosperity, negative health outcomes, and race and ethnicity. And in fact, we often talk about this in terms of dual disparities. So we know that there are very strong health disparities. There are notable health disparities that are tied to race and ethnicity. There are also very notable health disparities that are tied to geography by itself. And when you overlay race and ethnicity and geography, so when you look at rural minority populations, we see what we call dual disparities, and we see some of the worst health outcomes in the United States. So just to kind of wrap this piece of the presentation up, and all of this data is available. So you see the website at the top. So we developed this prosperity index as part of our opioid misuse tool. And so the website is opioidmisusetool.norc.org. And when you click on a county, you can access the individual data from the Prosperity Index. This is a county very close to me here in Tennessee. It's about 2 counties over. This county within Tennessee ranks 94 out of 95 counties on the county health rankings in Tennessee. And you see that this is a county that struggles in terms of these measures within the Prosperity Index. Again, you can pull this up for every county in the United States, and what you will get is your composite overall Prosperity Index score. You will get the scores for each of those cells that I mentioned, so economic risk, economic resilience, social risk, and social resilience. And I think most importantly, you will get the data for your county compared to your state, compared to the nation. And again, we hope that people within communities, as they're thinking about ways to bend the curve in terms of health outcomes and health disparities, that these are measures that they will be looking at and thinking about as ways that they may be able to improve their prosperity and their overall health outcomes. So I show Hancock County for a reason, because I have a friend who lives up in Maine, and he's in Hancock County, Maine, which is also a very rural county, but looks very different in terms of prosperity. So, you know, the big message here is just because you're in a rural county, it's not determinant of your prosperity. There are things that we can be doing in our rural communities to really increase resilience and decrease risk. And I'm going to show you that even in those counties that struggle economically, that's not determinant of the health outcome. So I will tell you that I'm beginning to struggle more and more with this phrase we use in public health where we talk about social determinants of health. I'm not crazy about the word determinant because it sounds like it's something that is not changeable. What we find, what I hope that you will see from this presentation, is that poverty is predictive, but it isn't determinant. And I'm going to show you at the end some work that we're doing in Eastern Kentucky that I think really probably demonstrates that better than anything I've seen recently. So here's kind of where I want to pivot a little bit, because in rural health, in public health in general, most of the time when we are funded to do research, we are funded to articulate and investigate challenges. And the same thing happens in the media. When they write stories, they're looking at our data and they make really compelling stories. And to the extent that these stories, to the extent that our own research drives the narrative about our rural communities, it can become very negative and dystopic. And I worry that if we believe, and I do believe this, if we believe that the economic conditions of our communities are strongly tied to the health outcomes in our communities, the answer to that is to lift up our communities economically. And if the predominant narrative about our rural communities is negative, it's hard to get people to invest in our rural communities. So this is really, I think, what we need to be addressing head on. And so kind of with that, I want to talk about strengths and assets in rural communities. And this is work that I will tell you was really transformative for me personally. I've been a rural researcher my whole career. And you know, I can tell you every problem in rural communities. And again, it creates a negative story. Robert Wood Johnson Foundation actually provided us with funding to do the opposite. It was really cool work where they funded us to go into rural communities all over the country and talk to people about what was positive in their communities. What were the strengths in the communities? What were they proud of? How were they coming together as communities to address problems? And that, I think, is not only a more positive, obviously a more positive way to think about rural communities, but I think in doing so, we start to think about those assets that we have that can be leveraged to improve health and well-being. So for this project, we talked to over 400 people all over the country, and we talked to them about their assets. We used a framework for asset mapping where we thought about these assets in different ways. So individual assets are the assets that exist within the people within those communities. So that is things like civic and community engagement, entrepreneurship, resilience and adaptive capacities, and specific population groups like youth and older adults and veterans. I highlight that because one of the things we often talk about in our rural communities is that they're disproportionately older, and that's true, but we also talk about that in a negative way, as though that's one of our problems in our rural communities. I think we could also be saying that in our rural communities, we have older people who have skill sets, who can volunteer, who can share those skill sets within their communities. Similarly, our rural communities, our rural youth are much more likely to serve in the military. They come home with skill sets that we can leverage. And just in general, we need to be providing more opportunity for our rural youth so that we retain that asset within our rural communities. Organizational or associational assets. These are assets that exist within local communities that are controlled within local communities. So that includes things like schools, faith-based organizations, small businesses, local media, locally run financial institutions. Community assets are similar. These are assets at the community level, but they're not necessarily controlled within the community. So, I think a great example of this is like your local Walmart, where it employs a lot of people. They donate money back into the community, but it's not run out of your community. It's run out of Arkansas. And there are a lot of those: food systems, land grant institutions, broadband infrastructure, larger employers, but they're still really important assets within your community. And then finally, this is the last category, and to me, this is the most important category. These are the cultural assets. And I think this is where we need to be focused a lot more within our rural communities. So we have close-knit communities where people know each other. There are strong social support systems and neighborly ties. A lot of pride of place. People are very prideful of the communities they come from. There's cultures of self-reliance and independence, a strong patriotism and loyalty, strong work ethics. We talk often about the social cohesion and how that can be leveraged within communities to bring people together to solve problems, shared history, and then my favorite is innovation and creativity. And this was something that was described a lot throughout our project for the foundation, where every community we went to all over the country, people said, if you are in a small community and you have a problem to solve, nobody is throwing money at you. The money is going to larger places with more people. We have to come together on our own to solve our problems on our own, and we can be very creative in doing so. So we are hubs of innovation because we're finding ways to solve problems without a lot of resource. And I think that's a really neat positive frame about what rural communities can accomplish. And so this is what it looks like when we start to map those assets. This is the completed asset map where we do this exercise with communities a lot, where we really bring people together to think about all of those different assets within their communities, engage in that positive conversation, and then talk about how all of this can be leveraged to really focus on the challenges that the communities face. So many of you may be members of the National Rural Health Association. I'm a proud member of NRHA. For many, many years, their tagline, it wasn't an official tagline, but when they went to advocate on behalf of rural communities, they would go in with the words older, poorer, sicker. And it was a really great way to get members of Congress engaged in putting money into rural programs. But again, it's not the way you want to be projecting your communities. I mean, you cannot go out and do effective economic development if your tagline is older, poorer, sicker. So I think as rural people and advocates and people who work in rural health, we need to be thinking about how we want to describe our communities. And I think if we describe them in terms of these assets, creative, collaborative, I think that we'll be much more successful in building up our rural communities. So then this is truly what I want to, oh, I'm sorry. And then this is where you can find information about this project. Please feel free to go access these briefs. We did a lot of, I think, great work for the foundation where we articulate this. So this is where I want to really wrap things up and hopefully have a nice dialogue. can we do this? So if you remember back to that map I showed you of persistent poverty, what you would note is that Eastern Kentucky is a persistent poverty region within our nation. It is Central Appalachia, some of the poorest counties in the entire United States. What you are looking at here are all of the states within the Central Appalachian region. And this is comparing overdose mortality rates across two timeframes, comparing 5-year aggregate data 2008 to 2012 to the next 5 years, 2013 to 2017. Green is the steepest declines, and the dark orange is the steepest increases in overdose mortality. Within Eastern Kentucky, you have many of the counties that have had the steepest decline in overdose mortality of anywhere in the country. And look down to West Virginia, and you'll see those counties that border Kentucky. Just right across the border, they've not shared in that experience. Right across the border in Ohio, they've not shared in that experience. So this is an example, I think, in terms of communities that struggle in terms of poverty, but are doing really well in terms of improving their health outcomes. And to just put some numbers on this, when we looked at Eastern Kentucky, what we found, we looked at every county in the United States, 3,200 and some odd counties in the United States. When we rank ordered every county in terms of decreased mortality rates between these two timeframes, 8 of the 10 counties in the entire nation with the steepest declines were in Eastern Kentucky, 8 of the 10, 14 of the top 20. That's remarkable in areas that struggle economically. And then when we looked at where these counties are in terms of the county health rankings, all of these were counties, even within their own state, that were in the lower half in the county health rankings. Most of these were in the lower quarter. And look at Clay County. So Clay County, of every county in the United States, Clay County has the steepest decline in overdose mortality. It ranks 117 out of 120. And then when we go back, I don't have that slide here, but when we go back and look at that prosperity index, this is a county that struggles in every measure on that prosperity index. So again, as I think about this more, poverty is predictive, but it is not determinate. So even counties that struggle in terms of poverty, I think can accomplish really remarkable things. So the question then is, how did they do this in Eastern Kentucky? And so we've been doing work for the Centers for Disease Control, where we looked at all of these counties within Eastern Kentucky. We used a positive deviance approach to try to think about what they were doing that was contributing to their declines. And what we found were a lot of really cool things. There's increased access to treatment in Kentucky. A lot of that came through their Medicaid expansion, but it actually predated their Medicaid expansion even, where community groups came together to provide vouchers to people who needed treatment. Medicaid expansion really, it added fuel to that though. When we looked at I think it was 6 quarters, but from the time that they expanded Medicaid to 6 quarters later, so a year and a half later, the number of people in treatment had increased 700% in Kentucky. And it wasn't just the Medicaid expansion, it was Medicaid expansion with a very robust treatment benefit. Other states that have expanded Medicaid without that treatment benefit did not have that same experience. A lot of focus on recovery communities, including recovery housing. One of the things in Kentucky that I think is notable is that this has been a bipartisan effort. The recovery housing initiatives were started by a Republican governor. His successor was a Democrat who expanded Medicaid. Throughout that whole time, their congressman, a Republican, has invested in that community and brought resources to that community, and just to focus on substance use disorder and trying to reduce stigma. All of these things coming together made a difference. You may be surprised, harm reduction. The state of Kentucky has more harm reduction sites than any state in the country. Most of them are rural. A lot of focus on reducing stigma, a lot of partnerships. These are the things, and again, when I talk about creativity, These are the things that communities can do when they come together and think about their problems and think about how they're going to address them on their own. And all of this was done with a lot of, without a lot of outside resource being invested in the community. All of that said, I don't want to be overly optimistic. I think this is a reason for hope and optimism, but we've also seen a rise of methamphetamine even as other drug use has gone down within the community. So some of this may be due to a shift in drug use patterns, which I think is notable. And then ground has been lost more recently due to COVID. And I think we need to really be watchful of what happens as a result of COVID in terms of overdose mortality, but also in terms of suicide rates, which we see going up dramatically as well. So I think that's where I'm going to end, and I will see if anyone has any questions.
So we strongly encourage you. Thank you, Mr. Meit. That was an excellent presentation, and we will definitely have these in the archive. In the interim, though, we strongly encourage, if you have a question, please unmute yourself and reach out to Mr. Meit. So anyone. Okay, well, I'll start. On the question of equity, which is always an issue here in this, as you know, our region is about we reach out to about a third of the state of Georgia in this part of it, and it crosses over to a couple borders state as well. However, equity seems to be is a major issue, particularly equity when it deals or dealing with persons of color. Any comments based on your research that you've seen that would give us some hope in a direction, either change or things that we could do, so forth?
Yeah, I certainly see the health equity challenges that you're describing. And again, when we overlay geography with race and ethnicity, we find those dual disparities. So one of the things I always point out is that rural white people do worse than non-rural white people. Rural Black people do not worse than non-rural Black people. It cuts across race and ethnicity. So there is this independent factor of geography that puts people at a health disadvantage. Mm-hmm. And there are independent factors of race and ethnicity that put people at disadvantages for health and well-being. You combine those two and we find this dual disparity. So it's very, very real. At the same time, I would also argue that there are cultural assets that are tied to both race and ethnicity and to geography that are independent as well. So I think we probably have within our communities of color in rural communities, I think we have strengths and assets that we can be leveraging that tie both to the rural nature of the communities as well as the cultural factors tied to race and ethnicity. And I think that's where we need to be looking. And in fact, when you look at many of the most successful programs within our rural communities of color, many of them are tied to the faith community, things like that. And I think that's really a reflection of that.
Okay, thank you. Other questions? Comments?
I'll say as we wait, I'll also add to that one of the things I struggle with a little bit is I think that as we have framed our dialogue around equity, I think people automatically think about race and ethnicity when they talk about equity. They don't automatically think about geography. So I think we need to be very intentional about focusing on that geographic piece so that it isn't lost in that discussion. And I think that's actually particularly important within our rural communities of color, because there is something about geography that adds to those disparities. And I think that if we're not intentional about focusing on that geographic piece, it's very easy for people to forget about it.
I agree. And then I would tie that back to the effort that you've made to show persistent poverty, and to know that what you just said is really a reflection of the history
That's
for the
right.
of this country for the most part, in terms of how persons, particularly those in non-metro areas, have been treated, uh, and how discrimination of of those types, and that includes all persons of all races. How that discrimination has occurred and played itself out historically in these areas as well.
Yeah. No, I think that's right. And it's, it's for me, it's very interesting. I'm in Central Appalachia. So here we do see that exactly what you described. We see that here as well without as much diversity. Our populations are less diverse than rural populations in other areas that are persistent poverty areas. But we actually see some common threads in terms of how people have been treated and stigmatized within our region. And a lot of that, I think, ties back to the history here with extraction industries. And it's very complex, but it's one of those things that I think about a lot. Is I think that our communities that experience persistent poverty throughout the United States, it's Caucasians in Central Appalachia, it's African Americans in the South and the Delta, it's Hispanics in the border region, and it's Native Americans. All of those populations have much more in common with each other than the people who have power and influence.
Right.
Trying to figure out how we bridge some of the dialogue across those populations, I think, is really a path forward.
Yeah. Yeah. Thank you. Okay. Others? Well, we have Mr. Meit here. Okay. So I a very excellent presentation. Just so that everyone knows, the presentation, as we have done in the past, the recording for this, as well as the slides and the information on how to get a hold of Mr. Meit, will all be on on our website, and as well as any additional questions that you might have. So we want to really give a great, Southern thank you to Mr. Meit, and I'm hoping that you all follow up with him as you see fit. He has said in previous, he's always willing to share information, and I can guarantee you that he responds, and also is very generous in what he shares in his research. So we are truly appreciative of that. Okay, so if we do not have any questions, then Mr. Meit, we want to thank you for your time. We will be following up with you ourselves on this matter. We want to thank everyone and want to invite you to continue to pay attention to our announcements for future seminars, which will be coming up very, very shortly. And we will have those from other collegial institutions, as well as persons at the national level coming up soon. So thank everyone for your time and effort, and have a good and fortunate week. Mr. Meit, thank you so much. And thank you. We'll follow up. All right, then. That's it for today. Thank you so much. Okay.
All right. Thank you.
Okay. Bye.